Good morning to my West Coasters and good afternoon to my East Coasters. Welcome to BioXcellerator's live discussion on osteoarthritis and stem cell therapy. I am Jennifer Waldrop, Director of Business Development here at BioXcellerator for the Healthcare Practitioner Program. Today, I'm joined by Timothy Thompson, who's a physician assistant with over 20 years worth of orthopedic and sports medicine experience. He's also a leader here at BioXcellerator. Our guests today are Dr. Robert Palumbo, who's an orthopedic and sports medicine surgeon from Philadelphia. He's also the team physician from the Phillies. We also have Dr. Rizwan Minhas, a non-operative sports medicine physician out of Toronto, Canada. He specializes in ultrasound injections for injuries, for arthritis, and also hormone replacement therapy. Welcome, Dr. Minhas. Welcome, Dr. Palumbo. Tim?
Thanks, Jennifer. We're going to get right at this, guys, and I hope you don't mind. Dr. Palumbo, 30 years in medicine, Philadelphia Phillies doctor, NFL consultant, U.S. women's national soccer team, biologics for 25 years, an early adopter, right, as it started out way back in the 90s. Dr. Minhas, you've got your college athletes, your wrestlers, your MMA and UFC guys. Let me lay the gauntlet down for you. 7% of the global population, 500 million people, have osteoarthritis. 32 million people in the U.S. alone, primary osteoarthritis. That's not to mention all the meniscectomies, the ACL surgeries, the inflammatory arthropathy patients that we have. That number is probably closer to 53 million just in the U.S. And we prescribe weight management and diet, and then we send patients off, and hopefully they do it on painful joints. And there's a lot of noise about PRP, and hopefully we're trying to figure that out after all the noise that's been out there. Now it's more invasive adipose harvest or bone marrow aspirate out of your pelvis. And then you have the opposite end of the spectrum. You've got almost 800,000 knee replacements performed in the U.S. every year, and a third of them aren't happy. Where do we take it? Like, what's the story? How do you counsel patients in your practices about their journey as they're going to navigate through this over the next, second half of their lives? Dr. Palumbo, go ahead.
I think Mohammed would totally agree with what I'm about to say. Listen, one of the most important things is what you were saying is that is diagnosed, okay? Diagnosed. There's plenty of people that are, baby boomers and millennials that have osteoarthritis that is cooking, and they just haven't been diagnosed with it yet. My biggest thing is, and especially dealing with younger athletes, is how can we prevent the progression? Okay, where is that going to happen? Because right now, we're going to have those numbers are only going to go up as the baby boomers go through and as the millennials are going through. It's going to be the more active the population has been, especially in organized sports over the last 50 years, the more injuries have occurred and more post-traumatic osteoarthritis we're going to have. And that's just what we got. Now, the key is, okay, what can we do? What can we do to slow the progression? What can we do to slow or mediate the progression? What can we do to possibly reverse some of the progression? And so all those things are what we're trying to figure out with biologics. And all the things you talked about, PRP, exosome, bone marrow aspirate, fat aspirate. Listen, that's all we have in the United States. That's as good as we got. And when I talk to my patients about it, I say, at the very least, it's stem cell light. It's not even stem cells. We're not even talking about that. But it's the only power that we have. We also have, our knowledge on nutrition right now is getting so much better. Obviously, no insurance wants to pay for that knowledge, and so our functional medicine doctors, our sports medicine doctors that are really optimizing the individuals are getting the best results on any biologics or anything that we're doing. So that's something really we need to talk about. I mean, I hate to say it, and I don't, and Canada is so much healthier than we are, but we're in a bad state in the United States. Obesity is an epidemic, and we treat it as a condition that we don't really take it seriously, even though We say we do not, or we wouldn't have, almost 60% of our youth overweight. So, we need to really focus on what causes osteoarthritis, what we can do to slow post-traumatic osteoarthritis, and what we can do to mitigate progression. So all those things are things we got to work on, and it's a multidisciplinary approach. So that's where we are right now.
Yeah, I think a couple of years ago, sorry, Jennifer, but a couple of years ago, when a lot of people got sick, the mortality rate was through the roof for people that were obese. You would hope that would have changed something. That would have changed people's mindsets.
Dr. Minhas, United States, it's a right.
Dr. Minhas, talk to us about the Canada experience.
So Rob, I wouldn't say we're better than you guys in regards to obesity. We're right behind you guys. So we're following America like we normally do, and we're right there with you. But currently, osteoarthritis, it's an age-related disease, but younger and younger people are getting it. Why? Could be some hereditary component, but could be lifestyle component as well. And obesity is obviously one of the factors that affects how much of joint pressures that you have, whether it's your knees, your ankles, even arms and even your arms and hands. But the thing with osteoarthritis is there's not one method of treatment. So far, we're limited to what we can do in Canada. We're limited. We can't even do bone marrow aspirate. We can't even do adipose procedures for so-called stem cells. But what we are limited to is this visco supplementation, which, to be honest, there's two varying thoughts. It may work, it may not work. The latest guidelines, the latest research reports show that they're not as effective as we thought they were. And then you have these cortisone injections, which are supposed to be used for osteoarthritis every 3 to 4 months, but apparently they're more detrimental in the long run. Right. So in Canada, we're limited to what we can use. That's why I actually joined you guys with BioXcellerator. You guys offer IV stem cells, but also joint injections specific to the patient's needs. And we'll talk more about what stem cells can do compared to what we have in Canada.
So it's a great segue, and there's a bunch of questions come through, and we'll get into that as we go through this. There's some questions about, I've had an ACL tear, ACL reconstruction. I've had, meniscus surgery. No matter what, Dr. Palumbo, correct me if I'm wrong, that patient's going to end up with arthritis.
No, they've had their sentinel event. Okay. They are on their way to arthritis. No matter if you have a perfect ACL replacement, you have had damage to that knee that will start to cascade to osteoarthritis. Percentages at the 20-year mark is upwards to 80%. So you just the fact that you have that injury is you will by definition have arthritis. So the question is, again, what do we do to mitigate it? What do we do to what lifestyle changes can we make? What can we do as far as nutritionally? And really, and I've been a believer in this, as you guys know, for many, many years. I've been replacing cartilage in people's knees since 1997. So there are things that we can do. There are things, and as you guys know, big believer in cultured stem cells like we do at BioXcellerator. But we can do a lot of other things. I am kind of a believer in doing a shotgun approach. I am a believer in using viscosity. I'm an engineer by some of my training. So anything that increases the slipperiness of irregular surfaces is going to help. May not change your pain scores very quickly, but it will. I do believe it does decrease. It does slow things down. It gives the environment in the knee to be somewhat better. Obviously, the other biologics that we could use also will help create a better environment within the knee and local environment. But as I said, at best, stem cell light. And, so that's why I was a very early involvement with BioXcellerator.
Yeah, and maybe Dr. Minhas, talk a little bit about what your expectations are with direct injections into joints that have arthritis. Again, you hear a lot about stem cells that are given IV for joint pain. Is that really helpful? Talk to us a little bit about the pathology and the chondrocytes and the inflammation around the synovial capsule that will cause these patients to be stiff and sore with their exercise and daily activity.
Yeah, you know what? Take, for example, we'll talk about the knees. It's one of the most affected joints in osteoarthritis. And currently, what we do is when you have osteoarthritis, it's shown to be textbook wise a non inflammatory process, but in its core, it is an inflammatory process. Whenever you have damage to the joint, you're going to have you're going to have chondrosis, which is breakdown of your cartilage. And at the same time, your joint space, the narrow, is going to get narrowed by the year. So it is a multifactorial approach. Put weight loss, nutrition on the side. In regards to in Canada right now, we're doing visco supplementation, which actually helps with the frictional improvement. It's basic hyaluronic acid. We inject it into the joint. I've noted that it lasts maybe 3-4 months. In some cases, good cases, you have some visco supplementation that last up to a year. But again, the mode of entry should be at the site of injury. So if you're doing knees, you should do an ultrasonic guided approach. Try to get it appropriately to the site of injury. We use a suprapatellar approach. But again, those viscous supplementations don't last as long. Cortisone, I'm not a big believer. It actually worsens your arthritis. So what do we have left? PRP and eventually stem cells. So stem cells, the mechanism is basically there's many ways of stem cells. In Canada, we are not allowed to do stem cells, but in the States, I think they're allowed to do some bone marrow and some adipose stem cells. In those stem cells, you're basically in the bone marrow aspect, you're getting your stem cells from one of the hip bones, which you're doing another invasive procedure and which may have its own complications, but you're not getting high quality stem cells and you're getting very low amount of stem cells. The best way I've noted from research thus far is umbilical cord stem cells, which you can also increase in number as well. So how do those stem cells work? Basically, they have growth factors and anti-inflammatory cytokines that when injected appropriately to the site of injury, they can decrease your inflammation acutely and in the long run prevent that pathogenesis of arthritis from forming.
Yeah, there's some good case studies out there that have, you know, that show both via MRI and from patient-reported outcomes that there is some chondrogenesis, there is a decreased inflammation because of the way the cells are working. The cells that we use are conditioned specifically to work in joints or low oxygen environments. What the research has found is that these cells that are grown in a hypoxic or lack of oxygen environment, just like the knee or the disc or those types of things, work better. They're more resilient and they're more potent, as well as the exosomes that they secrete. So our treatments are now a combination of those hypoxic cells and those exosomes for that maximum effect and longer term effect. Sorry to interrupt you, Jennifer. Go ahead.
Oh, I just thought this was a question came in regards to where are we getting our umbilical cords from? That's something that Minhas just touched on, and I thought you'd be a great person to elaborate on that.
Yeah, so all of our cords are donated from mothers. Our clinic is located in Columbia, so all local patients. Our team is actually there to hold that chain of custody 100% in house, right? So our team will collect the umbilical cords. They'll bring them directly to our lab, which is connected to our clinics, our cell bank, our clinic, our research team. Everybody's in house in the same facility. So the chain of custody, we know where the umbilical cords that come from. We know how the cells are being cultured and expanded, tested 6 times prior to anywhere close to application for microbiology, as well as viability and potency. So we can talk more about that donor program if we want. But again, real quickly, mothers between the ages of 18 and 32 years old, voluntary donation, uncompensated. So there's no bias in health history, tested for health history, tested for microbiology, full term, non-complicated, non-emergent C-section. This way they're the cleanest cells possible. And cells that don't meet those qualifications are not used.
And Tim, one of the things you kind of glazed over it, but these are all cesarean section births, which
all
is
cesarean section.
very important because the going through the birth canal really contaminates a lot, and so when you have a sterile C-section, you're getting a sterile piece of the umbilical cord and then using that Warfarin's jelly to then culture the cells and expand the cells. That's clean, and that is what that is not necessarily what is done everywhere. The other thing I think we need to differentiate something between BioXcellerator and some of the other stem cell clinics that are around. Our lab is right next to our clinic by basically a pass-through window. And we know that even within the first 15 minutes of thawing cells, there's a lot of cell death. So in many other clinics, there's a lab and then they're transported to the clinic. And we know that there's a lot of cell death and cell problems going there. So we tried, the one thing, and again, one of my criteria of being part of this for 8 years was, it's got to be the best. It's got to be university standards. And I think you could talk to a little bit about what that means with our clinic, because it really differentiates us.
Yeah. So as you mentioned, our ISO certified lab is full length ceiling to floor window, so you can see how things are being prepared. Right. We know the sterility from start to finish when we pick up the umbilical cords and bring them to our lab. Our lab meets or exceeds all international good manufacturing practices. So we can guarantee, and there's not a lot of guarantees in regenerative medicine. You guys know this, right? But what we can guarantee is the viability, the potency, and the sterility of our cells. That's going to give you the best opportunity to have a good outcome. And not a lot of people can do that because they're buying their cells. They're getting them from research facilities that say for research purposes only. There's no sterility. There's no lab processes for reactivation if they're frozen, because if they're frozen, they have a cryopreservant. And if you're just thawing them in your hands or warm saline in the back table in the clinic room, then you're getting that cryopreservant with you, and hopefully you don't have a sulfur allergy in most cases. So again, the transparency of the process from start to finish is second to none, right? And that's important when patients are spending good money and want to have good outcomes, right? Yes. So, we talk about all these things, but what does the evidence say, right? From both of your guys' perspective, you've both been to clinic, you've been to lab, you've seen how these work. You've referred us patients. How have those patients done, and what have you seen from a case study basis?
You go do this first, huh?
Yeah, so before I'll get to that answer as well, but you're right in regards to having a cell bank is very important. I have a lot of physicians in this area in Canada. They order stem cells from different companies around the States, and sometimes they're at the border for about 7 days. So I don't know how well preserved they are, and there's an ethical issue involved with use of stem cells and financial issues involved as well. So whenever we have patients, we send them to you guys or other stem cell companies around the world, but I prefer BioXcellerator because I've seen it for myself. Now, in regards to the data of how patients have done, I've had two patients that have gotten stem cells, one with a partial ACL tear, and I've had MRIs before and after. And this person, me and my fellow physician here at the Institute of Human Mechanics looked at his MRI post his stem cells after about a year. And to my surprise, the ACL had repaired. There was no ACL tear that was seen previously. In regards to the cartilage loss, I explained to him like the umbilical cord mesenchymal stem cells, they delay the destruction of cartilage, and not only delay the destruction, they actually help the expression of matrix degrading enzymes, right, like the chondrocyte enzymes, and prevent that. So that can promote like the cartilage progenitor cells and heal arthritis as well. It seemed like his arthritis was less as compared to before, even though I've not seen many of those cases, but in this case, I had seen it. So an MRI did show that his ACL not only improved, but his chondrosis also improved.
That's awesome. So one of the things that we offer our patients for certain pathologies like knee osteoarthritis or degenerative disc disease, we'll offer to reimburse them for an MRI after a year just to see their progress. Right? Because again, there's case studies, there's animal models, there's a lot of data out there that says there is not only a chondroprotective effect as well as a chondrogenesis effect.
Genesis,
right?
yes.
And we're starting to see that at this point. Rob?
Yep. Doctor?
Well, I could talk about a lot of case studies I have, but my favorite one is me. Yeah, you guys know I've been treated in the past, and played football for 18 years, paid for it in many different ways. I've had injections into my midfoot because of Liz Frank injuries. I've had both knees injected, my right shoulder injected, multiple injections into my spine and discs. And I could tell you the difference has been amazing. I had severe neuropathic pain before, and again, I think I know we're on knee osteoarthritis right now, but as you guys know, some of our best results have been from our amazing results have been from spinal cord or nerve injury, and we have seen that. And now I can tell you from personal experience, yeah, it works. So, and as far as other patients, other athletes that we've seen, we have not gotten post MRIs on them yet, but we've done some ultrasounds. We've seen some improvements of what the meniscus looks like on ultrasound. We've seen improvements on ligamentous structures that we may have, or rotator cuff. So I know, and which is the reason now we're writing protocols on not only treatment but prevention and convalescence. Post-season treatments and things like that, which I'm most excited about, and hopefully we'll be talking about the results in about a year and a half, early results on that.
Well, that you're gonna see, the BioXcellerator research team and medical team, they're starting to present our patient-reported outcomes worldwide, right? So for spine and disc and for knee osteoarthritis, we have those. Our patient registry, all of our patients are in that registry, and they answer these patient-reported questionnaires or validated questionnaires after, and then hopefully getting the MRIs after a year. Our patient-reported outcomes from our database are on our website. So if you look at knee osteoarthritis, these are all comers from mild stiffness to debilitating pain when walking, and you're seeing good pain scores or better pain scores, improvement in pain scores, and significant improvements in quality of life. So we know what we're doing is working in the entire patient population. Now, obviously, the worse off you are, hopefully you'll still have effects, but they may not be as great as somebody that doesn't have as worse off arthritis. But again, we publish all those in an effort to be transparent about what you can expect while you go through stem cell therapy. There were a couple questions that I wanted to get to real quick because I want to make sure that people realize that we're getting. There's one that said, "What's the suggestion for torn ACL and torn meniscus?" Well, it depends on who you are and your age. If it's someone my age, I'm coming close to 50 years old. I know I'm going to get arthritis quicker than a 20-year-old. So it depends on who you are and your pathology. There's another question that came from, do you inject ligaments in the atlas axis? We don't do that for instability up high, but I want to make sure that was asked. Another question came in, Dr. Palumbo, maybe you take this one. What's PRP?
Okay.
The most basic question. Let's start there.
Let's go back.
How is it different than?
Want me to go to the first question about the ACL, or do you want to go to the PRP first? You tell me.
Let's you take the PRP one, and then we'll send Dr. Minhas the ACL question.
What PRP is? It simply stands for platelet-rich plasma, and what that is, we take a sample of a person's blood, just like any venipuncture you'd have for getting blood work. We take about 50 cc's, about 2 ounces of blood. And then depending on which system you use, and we all use different systems, which is one of the problems with the research when it comes to PRP, we all use different systems and different concentrations, but we will spin that sample of blood within a centrifuge, which basically pulls out the density layers, of what is in there. And there's one layer that's packed with the platelets. And why is it so important to have the platelets? Well, the platelets is not as important as what surrounds the platelets. Within that layer are where there's the largest concentration of signaling proteins, exosomes, cytokines that are beneficial for what we're talking about, signaling the body's own reparative mechanisms. Basically, it's just like priming the pump, hopefully priming the pump, for the body to help recover from injury. So it's probably the least form of the body's activation that we have, but it's also the cheapest form. And we could kind of get patients to use it more. Now, I usually use a series, which also increases costs and things like that. But again, some of the things that we're doing because it's best we can, and that's all people could afford. Now, when you go, the difference between that and when you say cultured whole cells, like we use cultured stem cells, like we use in BioXcellerator, we know now. People think, oh, those cells get incorporated and they last and change the body forever. Those cells only last for about 6 weeks. Okay, but then what they're doing is producing all those factors that get the body supercharged to repair a particular area. And so, the magnitude of difference between what we could do with trying to prime the body's pump to recover using PRP versus what we're getting using cultured whole cells is this magnitude is different, power is different. So, like I said, sometimes you have to use whatever you got, but there is limitations to it because what you're giving is all they get. They're getting the factors that you have surrounding those platelets. They're not getting any generators like the whole stem cells that will be there.
And you mentioned different systems and different formulations and those types of things. And what are you actually starting with, right? Is anybody doing a blood draw ahead of time? Or do you have platelets to?
And here's the problem with research on all this. The problem with research on all this is that who's going to pay for it? Okay. We've been told that it would take about $250 to $500 million to do a study on cultured whole stem cells in the United States. Well, if I could open a clinic anywhere I want and I could control my process anywhere I want, who's going to pay for me to have the ability to do that? All right. It's not a big pharma company. They can't control it. Okay. You're starting to see some study, some FDA studies on, say, exosomes, which are the little signaling proteins that are surrounding the cells that we use and also surrounding within the PRP. Starting to see that because they can control the manufacturing. They can patent the way they manufacture. So somebody could actually control that study to get it through. The problem is with which would be the gold standard, cultured whole stem cells, that nobody's going to pay for the research to get it through the FDA ever because nobody can control it.
That brings up a good point before we get to Dr. Minhas. Somebody asked, when is this going to be legal in the United States? And it's so you can get umbilical cord cells in the United States and they can be bought from somewhere.
We do it now.
From somewhere. Right.
It's a basic, and again, we have some of the best microbiologists in Columbia working with us. But again, this is a junior college level microbiology class of what to do with these cells. It's not the technology. It's not the science. It's the FDA and getting it through when unfortunately our access to treatments goes through a organization that is basically funded about 88% by big pharma and equipment companies.
Right.
Not to say there's any bias there. However, the potential for bias is there.
Yeah. So anytime you get umbilical cord cells in the United States or exosomes in the United States, whether it be from a chiropractor, functional medicine doctor, or orthopedic surgeon, it's uncontrolled where they're coming from.
Yeah. It's people use the word stem cells very poorly in the United States. They use it as a marketing tool. And most of the time, it's not anything close to stem cells. They'll use micronized umbilical tissue. They'll use all these things that, have factors around them that will kind of prime the the body to try to heal itself. But the term stem cells is, and again, we do bone marrow and fat aspirate procedures in my practice. We do that. Again, it's all we got, but to say we're doing stem cell treatments, it's hard to say that. And I rarely use it. I usually, in my practice, it's cell-based therapies. That's all I can tell.
Dr. Minhas.
Yeah, Tim, I wanted to add something to the PRP. So in Canada, we're allowed to do PRP only, and the limitation of PRP for arthritis, it depends on the grade of arthritis. If you have a grade 3 arthritis, or if the cartilage is all worn out, or severe arthritis, whatever your term you may use, it's not as effective as stem cells would be. The other limitation is age. You have PRP from young adults is far superior than PRP in the elderly population, which are more plagued with arthritis. Why? Because in young adults, you have higher concentration of platelets and higher concentration of these growth factors. So PRP has its limitations, and having stem cells as a choice in the elderly population may be more beneficial.
And I totally agree with that. And the problem within the United States, as far as taking bone marrow, if a person's over a certain age or certain physiologic age, for sure, I won't even use it, because it's truly a waste of money, because there is a big drop off in the amount of fat, stem cells within fat and within bone marrow as we age.
Yeah, guys, there's our live questions are blowing up right here. So let me get to a couple of these real quick. Number one, how about severe degenerative disc disease in the spine? Can you regrow spine bone? I don't think you want to regrow spine bone, but Dr. Palumbo, you've had your spine done. Talk to us about your disc experience.
All right, so just a little background. I am, again, had severe spine injuries, and my spinal cord is significantly damaged in my cervical spine. And so I've had multiple levels fused at this point. I'm now fused from C2, that's the top of the neck, to T2, which is the top of the back, and from L2 to S1. Okay, so most of my back, except my thoracic spine, is fused. So what do you want to do as far as before it gets to that point? There are things to slow the progress, okay? There are facet injections, just like our pain specialists do in the United States. They give cortisone, but you can give treatments called stem cell treatments to those facet joints. You could preserve whatever, as long as the annulus, as long as the covering the disc is intact, okay? You can inject cells into that disc, and they'll stay in that disc and help regenerate the disc. What other things is very important when it comes to spine, especially in people that are fused or have severe level? It's the levels below or above that you want to preserve. So I've had multiple thoracic discs injected as well, okay? And you do see the difference in the quality of disc on MRI. You do see that change. And so listen, if you're collapsed bone on bone, vertebrae to vertebrae, there is not a lot you're going to do with any disc there. Now, could you do some work within the spinal canal itself, intrathecal cells? Yes, that may be very helpful for when you're getting irritations or problems with the cord itself. Similarly, you could do facet injections, which may help that mechanical pain somewhat as well. But you definitely would love to catch it early on. That's why I encourage a lot of my active athletes, whether they be pro or if they have an injury, pay attention to that injury, and they want to preserve, and I use, biologics, to, again, anticipate this is going to go badly, and what can I do to stem that tide? So That's why, we talk about arthritis in older people. My shift is very early. I'm sure Mohammed's is as well. My shift is trying to shift those treatments early to get them in earlier stages, so they don't progress. That is where I'm working. That's my group that I'm working with. Now I have two other partners that do biologics in my office that, do a lot of osteoarthritis in older individuals. And it does, it does help in a lot of cases. But as Mohammed referred to, it really depends on where you are. And the other thing about osteoarthritis that we don't talk about a lot, we talk about is cartilage loss. Bone pain in osteoarthritis is one of the worst parts of osteoarthritis. And those of us that look at MRIs will see the bone light up bright white, okay? Which means the bone is irritated. The bone has a problem. The bone has a lot of edema. One of the things that is amazing when you do biologics is how fast that edema goes away. And and what we do in the United States, we actually will inject directly into that area, and we'll be doing some of that in BioXcellerator coming up pretty shortly as I educate more.
Dr. Minhas, talk to us a little bit about what your expectations would be for meniscus tears. This keeps coming up, right? So meniscus tears, once you have meniscus tear, those hoop stresses are disrupted. You're going to probably end up with arthritis. But do you think, in your opinion, with what you've seen in ACL, that partial ACL tear, do you think it would have that same effect within the meniscus?
You know what? There's a question we missed about the ACL tears, so I'll try to tackle both of them. In regards to ACL tears, when you have an ACL tear, you have to decide if it's a partial versus a full ACL tear. But you know what? In these cases, the examination or physical examination is more important than the actual imaging as well, or as along with imaging, physical examination is equally important. If their knee is not unstable, if they have good stability, it's not unstable, meaning the Lachman tests are negative and they're not having drawer signs that are quite evident. These orthopedic surgeons, despite these partial tears, don't like to do surgical intervention in these cases. They'll just send them off to do physiotherapy. But what you don't understand is when you're doing physiotherapy, that's great. But in the long run, over the years, because of that tear, you're disrupting the inflammatory process inside the knee and you're causing the inflammatory process to worsen and progress. Because sometimes when you have these ACL tears, you miss these meniscus damages as well. And going to the meniscus damage, when you have a meniscus damage, it's you have more friction. It causes this inflammatory cascade to worsen sooner than age-related normal process of worsening. So, the answer is if you don't get a surgical intervention because it's not a full ACL tear and just a partial tear, and you have a meniscus damage along with it, yes, having an early intervention with something like stem cells to diminish this process from continuing is helpful. Sometimes what I do now is because I don't have access to stem cells 24/7, I do a bit of PRP along with, say, a visco supplementation, even though it's not as effective, but the visco supplementation ends up protecting that meniscus and protecting the worsening of that meniscus. It promotes more like fluidity within the joint and causes less of that friction. So stem cells will come in. I mentioned this before as well. These stem cells have growth factors, cytokines, and ligands that help reduce, not only repair the cartilage, but also reduce the damage of worsening to the cartilage by these cartilage progenitor cells that can potentially heal this meniscus and these cartilages as well.
Yeah, it's one of those things. To the same vein, that the follow up to that question is, or should I just get a meniscectomy? Which you're not even giving yourself a chance at that point, right?
That's exactly right.
You're adding to the generation of that joint sooner than
the other thing is,
Yes.
what we are doing more now is actually repairing tears of the ACL. We are getting more and more successful because we have just better instrumentation to do that. We're already using a device that has some growth attraction on it from one of the industries, one of the companies that many of us use. But to add some biologics to that treatment when you're hoping for repair of that tissue to bone or tissue to tissue, that's something I try to convince patients to do all the time because, and again, it's an additional cost, but I've been doing PRP for meniscal repairs for a long period of time after suturing them together. putting that in there, doing it for patella tendon repairs or patella tendon, jumper's knee and those kind of things. I've been using biologics a lot for that. So we know, and we do have some good literature on certainly patella tendonitis and those kind of things. But the fact that we are going towards repair on the ACL, biologics becomes even more important.
Yeah,
and we've seen an uptick in that with some of our athletes too that need an ACL reconstruction, that have a bucket handle meniscus that has to be flipped back and repaired. We're seeing them come down about 4 weeks after surgery to get the stem cell therapy to make sure that those things that are repaired surgically actually do heal and do what they're supposed to. Go ahead, Dr. Minhas.
Yeah, the question about meniscectomy, should you go right to it? Again, it would depend on the patient's symptoms, right? And the stability of their knees. Just, for example, the research, everybody knows this. Whenever you have a total meniscectomy, you increase your chance of arthritis by about 14 times compared to the average population. So it's not an easy thing to do. The only time you would get a meniscectomy is if you have unstable symptoms, if your knee is unstable. And say that you do go for the partial meniscectomy, the goal of that meniscectomy is to preserve the rim of the meniscal cartilage, right? And remove only unstable components. But if you do get it, again, you're at risk by 14 times more so than the average population to get arthritis. How do you mitigate that risk and lower down the risk? Nowadays, Dr. Palumbo basically mentioned they're using PRP to basically decrease that risk. And again, stem cells will help you decrease the risk of worsening your arthritis after a meniscectomy. But if you can avoid it, I would avoid it.
And as you know, Tim, you've been in orthopedics for a long time as well. It really depends on the quality of the meniscus tissue, the type of tear, which side it's on. I mean, we know that lateral menisci are a bigger problem than medial menisci, and to trim out a portion of the lateral meniscus, and certainly if you have a tear that is not repairable, we know that person's going to go to arthritis. So it depends on the patient, depends on the alignment, depends on the quality of the meniscus, that is it healable or not. So it does depend on several factors before you would make that. But certainly if it's asymptomatic, something so bad surgery could make worse. So so you're not going to treat it.
Yes.
You're not going to treat it surgically, but you would love to treat it biologically.
And that's, Rob, you just bring up a really good point. And some of the questions that came through is, what's the process? Do we need an MRI to start? So just the BioXcellerator process, we can't speak for all the other clinics, but everybody that becomes a patient of BioXcellerator gets a virtual medical consultation with their doctors in Colombia, all the images, and we do require images before treatment, whether it's for a knee, a shoulder, MS in the brain. No matter what you're being treated for, you have MRI, CT scan, whatever appropriate imaging is for that diagnosis will be reviewed prior to therapy by our specialists.
Okay,
so it's not something that we say, oh, if you get knee pain, you've got arthritis on X-ray. Let's throw some cells into your knee and hope for the best. The second part of that, I think, and probably just as important, is the follow-up. And somebody asked, what's the rehab after these things? And if you can both comment on the focused physical therapy that we do in regards to stem cell therapy. It's not just a shot and go away. These are lifestyle changes that people are going to have to make.
Absolutely. And like one of the, again, I'm an orthopedist, what do I know about real medicine? But that was for Muhammad. Basically, there's a reason why it could take up to 6 to 8 weeks to get a patient in. Okay. Because we want them to understand the importance of nutritional, anti-inflammatory diets. We want them to be able to get all the studies that we need to make a good evaluation, because there are people we turn away. It's not like you call, you get in, we will turn people away because, yes, we are a business, but we're in the business of helping people that we could help. So it's very important for us to get those studies. The other good thing about, Medellin is that if you need studies, the ability to get them quickly while you're down during your visit is so easy. And the quality, I can tell you from patients I've sent and my own studies down there, are excellent. So, but you have to have those. You have to know what you're treating, number one, and you have to know the progress after you've treated it. Okay. If you don't have before and after, then you don't know how well you've done. And yes, most of our results are based on patients' complaints and their improvements. But we actually want to know, okay, is the biology helping the anatomy? And so we are very focused on that. Now, when it comes to post treatments, I'll tell you, it depends on the quality of the patient. What kind of shape they're in. What kind of are we talking about? A professional athlete? Are we talking about a 64-year-old guy that maybe is a little overweight, and has not been doing his exercises lately? What is emphasized when we have patients there is we put them through a physical therapy visit. Okay, so these people go home with a specific physical therapy prescription that is made just for them based on what they're going through. And yes, we expect them to do it. The biggest thing about biologics is people have to understand it takes time. It's not, they'll feel great after a steroid injection. Like, oh yeah, steroid works. And boy, this stuff takes a while. Yeah, it takes a while because it's biologics. It takes a while for it to work on the body and the body to repair itself. So we don't want to disrupt that in the first 8 to 12 weeks, so we don't want to do anything that, again, we don't want to cause re-injury during that time. Doesn't mean we don't want them to move. We do want them to move. And we do want them to put some stress on the joints, but we don't want them to cause injury to that joint. So again, it's individualized for every patient that comes down there. But basically, the first 8 weeks, we are careful to ensure that we're not overstressing the joint, but stressing it just enough.
Right. Dr. Minhas, I know you're on a little bit of a tight schedule. So, and again, there's a ton of questions that we can get to, but just some final thoughts. Talk to us about where you see this right now and where you see it going the next 1, 2, 3, 5 years.
Yeah, yeah. You know what? Final thoughts. It's about time these orthopedic surgeons stop doing these meniscectomies finally. But you know what? I'm glad we're at a stage where we can try to help people, prevent the worsening condition of their arthritis. Remember, with PRP, one injection is never good enough. You need at least 3, for a joint arthritis. Well, good thing with stem cells is it's a one injection, and it's not invasive. It's minimally invasive procedure. You're not getting your stem cells from your adipose tissue or from your spine or from your hip bone. So it's a one injection, and it's done really well. Along with that, as mentioned by the doc, you definitely need physiotherapy, but it's something at least we have. And to help, and you know what, your health is the most important to you, and you should get it. You should work on it sooner than later. Again, we don't want you to reach the end stage arthritis condition. We want to target it when it's mild to moderate.
It's interesting. Somebody said this the other day, and they said, well, Tim, why is this 4th stage treatment? Why do I have to go through activity modification, physical therapy, NSAIDs that are going to wreck my stomach and kidneys, all the other biologics, and then before I need a joint replacement, then I'm going to try stem cells? Why are we not doing this at stage 1 or 2? And that's a question that we can ask, we can debate on for another hour or so. But
I don't think it's a debate. I think, yes, we should.
We should, yes.
We should. It's not.
Right.
It's just the expense and what's allowed in both Canada and the United States. So if I have an professional athlete of means, or people of means that could afford what they could, I would send everybody down. I wish we could
buying pharmaceuticals easier than actual things that are going to heal things. So that's another discussion.
It makes more money for somebody else. That's why.
It's a total different discussion.
I'm trying to bite my tongue. Believe me.
Guys, we had some other questions that came through. I just want to make sure that we get to before we end. Can we treat Parkinson's disease? So that's a little bit of a tricky situation depending on the stage of the disease and your diagnosis and with all the neurodegenerative diseases like ALS and Parkinson's and Alzheimer's. So that would have to be a consult call with one of our medical doctors, have all your reports and documentation from your neurologists and doctors to make sure to see if we can help you or not. But that's certainly a tricky one. Another one came across that said, can we use stem cells from ourselves or our children? And the question is why? So if I'm 48 years old, I don't necessarily want my stem cells because they're 48 years old, right? Where I can have a stem cell, an umbilical cord stem cell that is an adult cell, but young in age. It doesn't have any HLA tails, which means your body's not going to reject it. There's no chance of graft versus host disease. So it's a safe and effective treatment. I would rather have that cell than my own cell at that point in time. And we know that banking cells for 15, 18 years may or may not be a viable thing. Somebody asked about how much do they cost. And again, that's going to depend on your specific protocol that you get. So we can't answer that question now. We do not use, and this is important.
In some treatments, cheaper than it would be in some of the major cities in the United States.
Right. So this is an important one, and it's one of the last ones that came across. Do we use embryonic stem cells? And the answer is unequivocally no. We do not use embryonic stem cells for multiple reasons. One, there's some morality issues potentially, and two, those cells have been shown to do some things we may not necessarily want them to do, and can potentially be tumorigenic, where the mesenchymal stem cells that we use from umbilical cord do not have that potential. So different type of cell, something that we do not use. And somebody asked, somebody's done their homework on this one. Are your stem cells live, and how many passages if cultured? So yes, everything we do is cultured and expanded. It's not available here in the United States. The cells are alive. Every single one of our patients gets a quality certificate that tells you the viability, potency, and characterizations of the cells that you actually received during treatment. So they're tested right up until the time they're applied. And that includes the microbiology testing for sterility to make sure there's no bacteria, viruses, fungus, or those types of things within our cells. Our cells have typically over 93% viability at the time of application. And all that's tested right before they're applied, which I don't necessarily know if you can do if you're getting these from somewhere else.
And also, Tim, what do? We increase what we give them by 10%. So if we're going to give you 40 million cells into a knee, they're actually getting 45.
Tim, they asked how many passages as well.
So how many passages? Now we talk about passages, and that's people that ask about passages worry about cell aging, right? And if they're passed too much, then they could lose their characteristics and potency. So our cells are passed between 5 and 7 passages, but more importantly is something called PDL. You do not want these cells pass and have a PDL over 30. So both our passages are between 5 and 7. Our PDL is typically between 9 and 12.
Explain PDL for.
It's a population doubling level. It's essentially you don't want to double these things so long that they have senescence or they have cell death, right? So we know that our passages between 5 and 7, our PDL between 9 and 12, that's the sweet spot for culturing and expanding these cells. Hopefully that answers the question. Like I said, somebody did the homework if they're asking about passages PDL. But I think that's a lot of the questions that have been answered. Somebody asked if can stem cell injections help with atrophy from a stroke. We do treat ischemic stroke. There is good evidence for ischemic stroke, not so much hemorrhagic stroke. But things like osteopenia, osteoporosis, sarcopenia, which is muscle atrophy, which happens just as much as bone atrophy does with age, all those things are helped, and we do have scientific-based protocols for those things to be treated with those things. As well as somebody asked about spinal cord injury in a 13-year-old. Spinal cord injury is a spinal cord injury, and those have a specific protocol that we can certainly talk about during consultation. But yes, for that patient or that person that asked if we can treat a 13-year-old with spinal cord injury, absolutely we have the ability to do that. Dr. Palumbo, Dr. Minhas gave some final thoughts. You've got 30 seconds. What do you want the people that are watching to take away from this? And
the answer is in the cells. The answer is the power in the power of the cells. I've been telling fellows that for 17 years, and I'm just so happy that the research is now proving that more and more. And we're getting better and better with our techniques of culturing and our and the treatments and protocols that we're developing. So, like I said, power's in the cells.
Okay. One final question that came in, and you guys will both appreciate this. At BioXcellerator, is a doctor doing this, or is like a nurse or someone else doing this?
It's a physician. It's a
We
physician.
have 12 physicians on staff. The majority of them are general practitioners that run the H&Ps and do the medical consultations initially, or run our research and our clinical care program, which follows you for 1 to 2 years afterwards. But all of our applications are done by either one of two sports medicine specialists, all under ultrasound guidance, or one of two neurosurgeons for the intrathecal or the intradiscal applications, the intrafacet applications done under fluoroscopic guidance are done by neurosurgeons. So you're not getting these from a nurse or even a PA like myself. You're getting these from well-trained, very well-experienced specialists, either sports medicine physicians like Dr. Minhas or neurosurgeons that are trained in these and actually teach in these applications. So hopefully that answered that questions as well. Jennifer, Dr. Minhas, Dr. Palumbo, any other thoughts?
No, thank you for having us.
All of our discussion. Yeah, great discussion. Thanks, guys, for everything. If you have additional questions or want more information, you can go to our LinkedIn bio, and there will be a link there for you to click in and get in touch with us. We appreciate your time, and thanks for joining us today.